A very pleasant evening to all of you. Welcome to a brand new episode of our academic program on obesity management, which is hosted by Docplexus in association with Center for Metabolic Surgery. Headed by Dr. Ramen Goel, CMS is amongst India's top bariatric surgery center and represents a comprehensive team of surgeons, physicians, dietitians, and psychologists to assist on weight loss surgeries. Program includes the expert opinion of our lecturers on their topics, along with patient testimonials and their experience about the treatment. I am very honored to be introducing our esteemed guest speaker for today, who will be talking about obesity, which is a major risk factor for diabetes, hypertension, myocardial infarction, and degenerative osteoarthritis. So our speaker would be sharing light on the medical management of obesity. So we have with us today Dr. Behram Pardiwalla. After schooling in Kolkata, Dr. Pardiwalla did his undergraduate and post-graduation from degrees from Seth Medical College and KM Hospital, Mumbai. He is also a postgraduate teacher for medicine and is also a teacher for the Diplomat of National Board of Examination. Dr. Pardiwalla is associated with many prestigious hospitals in Bombay, and he has also been awarded with the Sandalhurst Gold Medal and Vasant Khanolkar Prize when he was doing his MBBS. He is also the recipient of Bombay University Merit Scholarship and has been involved in a lot of CME's teaching programs, international and national conferences, and he is also enthusiastically participated in many teaching programs and has many publications and chapters to his credit. It's an honor for us to have you here, sir. I would now request you to please start your presentation.
Thank you very much. Thank you for that wonderful introduction. At the outset, let me thank Dr. Ramen Goel and CMS and Docplexus for asking me to talk to you on this subject. My topic for today is obesity, the medical management of obesity. That is what I'm going to be primarily talking about. So, in the medical management of obesity, this is the problem that we face, ladies and gentlemen. The problem is that obesity runs in our family. Unfortunately, no. The problem is that no one runs in your family. That is a major issue. Obesity is one of the biggest threats among NCDs in India. And if you look at the prevalence of these, 46% is obesity, 33% hypertension, and 26% type 2 diabetes. This is among the non-communicable diseases. And unfortunately, obesity has already reached alarming proportions in many parts of our country. Look at this. In 2005 and 2006, we had 3 states which had a 15% overweight or obese population. In 2015-16, exactly 10 years later, ladies and gentlemen, 19 states had more than 15% overweight obese patients. That's a huge number in just 10 years. And you will be shocked to know that 3 out of 4 Indians are overweight. Yes, 3 out of 4 Indians are overweight. And obesity amongst Indian children is on the rise. Between 1990 and 2014, the number of overweight children in the low and middle income countries doubled from 7.5 to 15.5. And in 2014, 48% of obese children live in Asia. Can you imagine? And Indians between 5 and 19 are increasingly getting obesity, primarily because of a westernization of our diet. And according to a report which was formed by the WHO, it has alarming consequences of blood pressure, type 2 diabetes, heart disease, osteoporosis, and various other factors which you know about. So these are some of the morbid conditions which are related to obesity. You can get atherosclerosis, diabetes, polycystic ovarian disease, hirsutism, hypertension, ischemic heart disease, osteoarthritis, obstructive sleep apnea, restrictive lung disease, and also cancer, especially endometrial, colonic, prostate, and breast cancer. So you can understand that if you treat obesity, you would be getting rid of a lot of these problems. However, you must understand that weight loss will improve obesity related complications only. If you want prevention of type 2 diabetes, then up to 10% weight loss is necessary. For remission of type 2 diabetes, up to 15% weight loss. For dyslipidemia, up to 15% weight loss. Hypertension, 5 to 15%. Non-alcoholic fatty liver, 5 to 15%. For obstructive sleep apnea, 10%. And for all the others, such as stress incontinence, psoriasis, gastroesophageal reflux, polycystic ovaries, asthma, etc., you need between 5 to 10% of weight reduction. You must understand why we start at 5%. It is because up to 5% weight loss can even occur with placebo. And that is what is extremely important for you to understand. What are the treatment options that we have for treatment of obesity? Diet and exercise, surgery, and medical. My job, ladies and gentlemen, is to talk to you about the medical aspects of treatment options. Basically, there are three mechanisms of action, three mechanisms for obesity medication. One is to decrease the food intake by reducing appetite or increasing satiety. The second is to decrease the absorption from the gut. And the third is the increase in energy expenditure. Unfortunately, the last, that is an increase in energy expenditure, nowhere in the world, especially in the United States, has this been approved. No drug has been approved. For example, ephedrine, norepinephrine, etc. These are drugs which are used to increase energy expenditure. But under the law, you cannot use it. Unfortunately, and I say it very seriously, unfortunately, a lot of gyms, a lot of gym trainers are using this drug in mixtures, especially one which is called Rip Fuel. And you will be shocked to know that I have lost a nephew of mine who inadvertently took Rip Fuel. Now, in the anti-obesity drugs, you have these Zenical, which is orlistat, Belvic, which is locazerine, Contrave, which is bupropion naltrexone combination, Kismia, which is a phentermine topiramate combination, Saxenda, which is liraglutide, dulaglutide, Trulicity, and of course, semaglutide. And I shall discuss some of these with you a little bit in detail. So looking at the pharmacological options for weight management, if you look at it on the left, you have orlistat, which you can see has been approved both in the European Union and in the United States. It acts by energy wastage. Phentermine is not approved in the European Union, as is phentermine and topiramate. That is also not approved in the European Union. Both of them act by appetite reduction. Naltrexone and bupropion, liraglutide, which is Saxenda, has been approved both in the European Union and the United States. But please remember, all of these are an adjunct to diet and physical activity for chronic weight management. Now, as you can see on the right, phentermine topiramate act at the GABA receptors and also at the noradrenergic and the dopaminergic receptors, while liraglutide acts in the gut and in the thalamus at the GLP-1 receptor. Naltrexone, bupropion, phentermine all act at the dopaminergic receptors, and orlistat acts on, of course, the pancreatic lipase. So if you look at noradrenergic agents, phentermine has no weight loss, less than 12 weeks. Fortunately, monotherapy has not been associated with valvular disease. But when phentermine was combined with fenfluramine, what was known as fenflur, at that time you had valvular disease occurring in the heart. But phentermine on its own does not cause anything, and that is why it has got approval. Phenylpropylamine has been approved as an over-the-counter appetite suppressant, but was withdrawn due to the risk of hemorrhagic stroke. So amongst the non-adrenergic agents, you only have phentermine which is available. Then you have the drugs which suppress appetite. And amongst the appetite suppressing medications are lorcaserin, which is a selective serotonin 2C receptor agonist. It increases weight loss from 2.2 to 5.8 kilograms compared with placebo. Unfortunately, as is the case with most of these medications, the weight returns to baseline after medication was stopped. It's been approved by the United States Food and Drugs Authority since July 2012. And you can see from here the lorcaserin effectiveness. It's very beautiful, and you can see that if you use it beyond 1 year also, that the effect continues. And what is beautifully seen here is this one. You can see that when you use it for 1 year, the weight loss is there. The moment you stop using it, you start gaining weight again. Then you have medications that reduce absorption. That is orlistat, which is available abroad as Zenical. It binds the gastrointestinal lipases, preventing hydrolysis of dietary fats. So what happens is about 1/3 of fat calories is excreted in the stools, and patients lose about 9% of body weight. As I told you, 5% body weight loss is always and can always be attributed to placebo. This weight loss, which orlistat gives, is associated with a decreased blood pressure and a decrease in fasting insulin levels. So it's extremely effective for patients who have a high insulin level or who are insulin resistant. Because it causes the fat to be lost, you should always take fat-soluble vitamins as daily vitamin supplements. Unfortunately, again I repeat, once the medication is stopped, weight is regained. And you can see from here, this is a normal function, and this is what happens when you give orlistat. The gastrointestinal lipase is blocked over here in the lower frame, and triglycerides, etc., are all excreted in the stool. Then you have phentermine topiramate combination, also called Kismia, which is approved by the US FDA in July 2012. Phentermine reduces appetite and decreases oral intake, while topiramate is an appetite suppressant and a satiety enhancer, acting at the hypothalamus. It's given daily in the morning because it causes insomnia. And believe me, it causes insomnia. If you take it at night, you probably won't sleep the whole night. You normally start in a dose of 3.75, 23 for 40 days, and then you increase it to 7.5, 46, etc., up to 12 weeks. At 12 weeks, if you find that you have less than 3% weight loss, you have the choice of stopping it or going up further, provided that the insomnia is not too bad, if headache is not too bad, if nausea is not too bad, you can increase the dose even to 11.25 to 69. Again, after 12 weeks, you recheck. If there is less than 5% body weight loss, you should stop Kismia. However, if there's more, you can continue it. And this is exactly what is shown in this slide. You can see what happens as the dose increases and the body weight continues. This is up to 56 weight, going right up to the end. And you can see the degree of weight loss when compared to placebo. Placebo is the blue one, and the pink one is 7.5, and the green one is 15 milligrams of phentermine, suggesting that with an increase in dose, you have greater weight loss. There is a significant improvement with treatment. And not only does your weight go down, but so does your blood pressure, your lipid concentration, and your blood glucose levels. So it's a win-win situation. But unfortunately, there are certain risks, such as nephrolithiasis, hypokalemia, dry mouth, paresthesia, constipation, and insomnia. And that is why in these patients, you need to keep extremely hydrated, right? These are some of the common side effects. Nephrolithiasis is something which people are really worried about when you take Kismia. Then you have the combination of bupropion and naltrexone. which is Contrave. It's a combination medicine which was approved in 2014. It was initially rejected because of cardiac problems in 2011, but later approved for adults with BMI of more than 30. It has to be given in conjunction with the weight loss program. In fact, I would not hesitate to say that all the drugs should be given in conjunction with the weight loss program. You should reevaluate at 12 weeks and it should be stopped if you have not got more than a 5% weight loss. Normally, the patients lose 4% more of body weight with medicine compared to placebo. So you're at about 9% total body weight loss. Nausea is seen in almost more than 30% of patients. More than one-third of them complain of nausea. And you do get depression and a suicidal risk. It sometimes causes a rise in the blood pressure. You then have what is a GLP-1 analog, liraglutide, better known as Victoza, which you use for diabetes, where we step up the doses from 0.6 milligram to 1.2 to 1.8 in treatment of diabetes. This is a once a day injectable. However, when you use it, and it's licensed in the USA for weight loss, Saxenda is the name, and patients lose 8% of body weight compared to 2.6% with placebo. I would like to emphasize here that Saxenda is not approved, or liraglutide is not approved in the Indian subcontinent for weight loss. So 3 out of 5 patients using Saxenda lost more than 5% body weight, and 1 out of 3, that's 33%, lost 10% of their body weight, which is really something which is remarkable. And here you can see beautifully the mean change in the body weight versus time. And you can see with the different doses what happens and the degree of weight loss. The maximum being here with Saxenda, which is 3 milligrams of liraglutide. And again, another thing to show you a loss from 233 pounds to 208 pounds, a 25-pound weight loss over a period of 64 weeks, which is substantial. And it actually doesn't give much of side effect. The initial run-in period, you do get a little nausea, but if you build up the dose gradually of Saxenda, then there is no problem. Then you have the other GLP-1 analog, dulaglutide, which is Trulicity. It's again an injectable GLP-1 analog. It's a once-a-week injection compared to Victoza or Saxenda, which is daily. You get up to 7 to 8% weight loss. However, there are some super responders who even have had 20% body weight loss. However, I would like to emphasize here that liraglutide in almost all trials has proved superior to dulaglutide in reduction of weight. I would again like to emphasize here that even dulaglutide is not sold in India for reduction of body weight. It's not licensed for that. Neither dulaglutide nor liraglutide. So when you look at the pharmacological options for weight management, and you can see the status and the mode of action, which I have already described to you, you can see that the dosing for orlistat is 3 times a day. For phentermine topiramate, it's once a day. For naltrexone, bupropion, it's twice daily. And for the injection, it is a daily injection. All of them are as an adjunct to diet for obesity, including weight loss and maintenance. And if you look at if you look at it, the weight loss which you can expect, 2.9% with orlistat, 8.6% with phentermine, 4.8% with naltrexone, 5.4% with liraglutide. And over the longer term, if you look at it, it's 2.8 with orlistat and 4.2 with liraglutide. If you look at the percentage of patients who achieve more than 10%, 26% achieve that in orlistat, 47% achieve it with phentermine topiramate, and 25% with naltrexone, and 33% with liraglutide. If you want 5% reduction, then almost all of them, look at that. Orlistat gives you 54%, phentermine gives you 67%, naltrexone, bupropion 48%, and liraglutide 63%. and you get good maintenance of weight loss as compared to the treatment before. We then come to the newest kid on the block, the latest human GLP-1 analog, which is semaglutide. And semaglutide, lot of studies have been done, step 1, step 2, step 3, step 4, etc. I would like to tell you that what I'm saying here is that semaglutide in any form is not yet marketed or available in India. Please understand that. It will be available very shortly, but as of today, it is not expected, and I have been strictly asked by Novo to emphasize that to you before using these slides. So if you look at the pharmacotherapy, you have, look at that, placebo 2.4% and 16.9% body weight change with oral semaglutide. February 2021, New England Journal of Medicine. This is a fantastic drug for weight reduction. With 2.4 milligrams, 86.4, 69.1, 50.5, and 32% had weight losses. 32% having a weight loss of more than 20. And if you increase the dose, it just keeps on going on. And it's unbelievable. I mean, you have to see what this drug can sometimes do. So these are the summaries for the step trials, 1, 3, 4, and step 2. And you can see everywhere that the weight loss is substantial. However, I'd like to emphasize again, please read on right on top on the right, semaglutide in any form is not marketed or available in India. Now, if you look at off-label use, you can use metformin, you can use the pramlintide, and you can use the SGLT2 inhibitor, just empagliflozin, dapagliflozin, and canagliflozin. And a very good combination for weight loss in a diabetic patient would be metformin, a GLP-1 analog, and of course an SGLT2 inhibitor. Just as an aside before I finish, you must understand that human chorionic gonadotropin was first suggested as treatment for obesity in 1954 in a Lancet paper. It became popular in 1970s, and the current popularity is because of Dr. Kevin Trudeau's 2007 book, which said that the weight loss cure that they don't want to know you about, and the miracle weight loss breakthrough. Very fortunately, the Federal Trade Commission ordered Mr. Trudeau to pay $37 million as damages for false claims with HCG. So, ladies and gentlemen, with obesity reduction, you can have an improved quality of life, a decrease in sleep apnea, an improvement in fertility, a decrease in gout, a reduction of blood pressure and diabetes, perhaps less cancers occurring, perhaps less coronary artery disease, and perhaps less gallstones. So I think that we should definitely try and control obesity. Thank you very much, and I'm open to any questions if you want. Thank you.
Thank you, Dr. Behram. That was a lovely presentation. And I would like to congratulate you because we had questions coming in right the minute you started your presentation. So people have been very, very zeal about it. So let me just read out the questions to you. Is that okay?
Absolutely.
All right. Okay. So the first question is from Dr. Jesh Seth, and he wants to know that how can childhood obesity be
I think
managed?
should avoid drugs.
Dr. Unnati, can you hear him?
No, I don't think. I think he got disconnected.
So I think somebody will have to talk to him.
Will change. You have
I
to
think he's
make
here.
them.
Yeah.
Sir, we had lost you in between the
Oh,
connection.
So
I'm
we had
sorry.
lost you in between. Okay,
I'm
no
sorry.
issues. No issues.
Yeah.
Yeah.
So I think you need a behavioral change. You have to have a behavioral change as far as these kids are concerned. And I think we should avoid drugs in children because drugs are much later. If you can make them eat healthier, if you can make them exercise better, if you can give them better drug choices, what we call medical nutrition therapy. Yes, please understand that dietary foods, they are not necessary. Today, I was discussing with my fellow when I had my lunch, and she said, "Sir, this is very tasty and it's quite nutritious, and it's very good." And I told her, "Am I there? Am I audible?" Yeah. And I told her, I said, "Yes, that's what's important in medical nutrition therapy. It doesn't mean that dietary food should be rubbish. They should taste like cardboard. They can be very interesting, actually."
So, sir, when you are saying behavioral change, is it the behavior of the child or behavior of the parents?
Both. Both. You see, the normal Indian tendency is मेरा बच्चा कितना पतला हो गया, उसको खिलाओ, वो तगड़ा होना चाहिए. You see, fat, unfortunately, in India is equal to a healthy status, which is wrong. That is the mindset which needs to change. Next question, Unnati.
Yes, sir. So the next question is basically a statement where someone is wanting to know that patient might be disappointed by the modest size of weight losses with medications. So how can one convince that medications are only adjunct to lifestyle changes, exercise, and other treatments for weight loss?
Look, you have to be very realistic when you look at weight loss programs. You cannot expect the weight loss to give you ad infinite reduction in weight. You have to temper your expectation. So if you make the patient understand that this is my goal and you have to reach it, not only with your medication, but along with your diet, along with adjunctive therapy of exercise and your changes in your eating habits, that is what makes a difference. Perhaps the only thing where you can lose 30% or 40 or 50% of your weight loss is when you go to Dr. Ramen Goel, right? But that is something which is totally different.
Correct, makes sense. So, Dr. Seema, I would want you to unmute yourself and go ahead with any questions that you have.
Hello.
Yes, ma'am.
Yeah, ma'am, could you just turn on your camera as well?
She's muted. Oh, no, she's there.
Yeah, she's here.
Yeah.
But,
Ma'am,
Dr.
are we
Seema, do you have-
audible?
Yeah. Hello.
do you
Yes,
have any
ma'am.
question for Dr. Pardiwalla?
Yeah. If I started with I start patient to early state, how many months I can continue with it?
You can continue up
Only-
to 2 years, ma'am. The only thing is you have to understand that since it gets rid of the fat, you have to give fat soluble vitamins A, D, E, K. So that as a supplementation you have to give. And let me tell you that patients who respond to orlistat complain of a lot of oily stool. I remember one or two of my patients actually told me, "Doctor, we get loose motion." So he actually used to carry soap with him. So if he had to use a public toilet, he could wash himself. It was that oily. So that is something that you must bear in mind.
Okay. After how many months, days I should go for LFT and serum creatinine done? After
For orlistat, it's not essential that you can do an LFT and a serum creatinine. I think that is more for the other drugs, the Kismia and the locazine, all those. That is those drugs are the ones which give you problems they cause dehydration, etc. Orlistat is relatively safe because it just acts at the cilia of the intestines.
okay, thank you, sir.
Sure,
Sir, can I ask you a question?
of course.
Now, out of all these medicines that you have mentioned, which one are really available in India? So I am aware of
Kismia is available. Kismia is available.
Kismia is available.
Yes. You can get Kismia. You can get liraglutide. You can get
Phentermine is not
dulaglutide.
available, sir.
Sorry?
Phentermine?
Phentermine is not available.
Yeah.
Yeah. But all the others are available. Semaglutide will become available, I think, next week or 10 days from now.
Yeah, I'm told the semaglutide tablets are also coming to India.
So this is oral semaglutide, which I showed you. Semaglutide, when you use tablets, unfortunately, they have to be given at a specific time, and the side effects are tremendous, right? So a lot of GI side effects. But if you tolerate the GI side effect, you can almost go up to 25% weight loss. And not only that, Dr. Goel, see, this is you had the Victoza, the liraglutide, then you had dulaglutide, now you have semaglutide, then you have terofetide, which is Lilly, which is going to come out in about 2 years' time, and that actually they jokingly said will drive the bariatric surgeons out of business because you can get up to 50% weight loss, 50%, but you have a lot of GI side effects. Please understand what I'm telling you is not yet marketed in India, not yet approved in India. But since this is a scientific discussion, I'm bringing it forth.
So, sir, when you say you have been very emphatic that these are not approved for India, so except Orlistat, is Orlistat approved in India for weight loss? Dr. Pardiwalla, we can't hear you. I think there is some internet problem from me. Dr. Unnati, can you hear him?
I think he's back, Dr. Raman. Dr. Behram, are you with us? Can you hear us? I think his video got stuck. No issues. I think, Dr. Raman, we can start with yours. Meanwhile, I think he'll come back.
Yeah, okay.
Okay, over to you, Dr. Raman. Thank you so much.
All right. So, friends, as Dr. Pardiwalla's internet, sir, you are back. Yeah, you are muted. Can you unmute yourself? Yeah.
Right. So I'd like to correct one thing, Dr. Goel. Liraglutide is available in India. Dulaglutide is available in India. Kismia is available in India. They are liraglutide and dulaglutide are not approved for weight reduction, but off-label doctors do use it, right? That is the thing. They are basically anti-diabetic medications.
So, how safe is off-label use in India in a non-diabetic patient if you are using it for weight loss? How safe they are medico-legally?
Well, let me get back to you with what once Dr. Preetam Patnani told us. He was a leading forensic expert, if you understand that.
Yeah.
And he told us, we were having our journal club, South Bombay Journal Club meeting. And over there, we questioned him about this. He says, all the doctors who are present in this meeting, you can use these drugs. The Supreme Court has said that medical progress cannot occur unless and until there are doctors who can push the envelope to find what they can do. However, such doctors should have enough experience of the drug. Such doctors should have enough experience in practice. Such doctors should do it openly with informed consent of the patients. And then the Supreme Court had said that the doctor is not at all liable. However, if you tell me that a junior doctor or a resident or a registrar or a junior, he may put himself open for.
Sir, I think there is some internet connectivity issue.
From his end.
Dr. Unnati?
Yeah, I also feel the same. So, was the question completed, Dr. Raman, or he was?
We can take it afterwards if required.
Yeah, we can. Yeah, we'll take it after your session then. Okay.
So, friends, after a wonderful talk from Dr. Behram Pardiwalla, who is a teacher of teachers, our mentor in Wockhardt Hospital, and we fall back on him for a lot of support for our bariatric patients. I wanted to share with you the management of medical problems after bariatric surgery. And this is to complement what Dr. Pardiwalla has already covered. And besides that, how do you manage diabetes? How do you manage hypertension? How do you manage gout? And likewise. So briefly, I'll show you a brief presentation, just about 5 to 7 minutes, and then we can take questions related to this and also what Dr. Pardiwalla was showing, discussing. So, greetings on behalf of Center for Metabolic Surgery, which is at Wockhardt Hospital, and I'm going to talk about what the physician should know about recommended medicines in bariatric patients. So these are basically in three categories. The supplements that are typically given to any bariatric patient after surgery to ensure that they are nutritionally well balanced, because the meal size is very small. And so this is I'll just spend a few minutes. Weight loss medicines, already Dr. Pardiwalla has discussed in detail, so I'll not be covering that. And then how do you manage comorbidities after bariatric surgery, because there are multiple issues involved. So as far as supplements are concerned, why supplements are required after surgery? Basically for these three reasons, that most of the population have pre-existing deficiencies. We know how almost 80% of Indian population has vitamin D deficiency. A very large percentage of population have vitamin B12 deficiency, and likewise. And generally, these are the deficiencies we check. We don't check for hundreds of them, manganese, magnesium, selenium, zinc. So we presume if there are more than one deficiency that we find, that means person has multivitamin and multimineral deficiency, and all of them should be corrected as a broad umbrella. Then there is surgical impact. So if we do a surgery where we are operating only on a stomach, like a sleeve gastrectomy, then the supplement dose requirement is less because there is no malabsorption involved. But if you are doing a surgery which is a bypass, then certainly the requirement is higher. And third thing is diet related. There are people who are vegetarian, there are people who are vegan, and after bariatric surgery, their requirements are different than, let's say, somebody who is taking a balanced diet which has enough protein in it and enough calcium products in it. So we'll briefly talk about it, so give you an idea. So most of the time, preoperative workup, besides routine tests that are done for any general surgery, we usually get their ferritin level done besides non-routine iron workup. We always get a B12, vitamin D3, and parathyroid hormone done. And we measure their serum proteins and albumin globulin ratio. These are important because this shows what kind of deficiencies they have. And if there are deficiencies, and if patient has time, they are local patients and they want to get a surgery done a month later or 2 months later, then we can start correction of these deficiencies well in advance before surgery. Many times it happens that patient just landed in Mumbai and we operate them. So we get these deficiencies assessed and we do the correction accordingly. We factor in that they already have deficiency and correct them. And these supplements basically involve 2 or 3 groups. One are the micronutrients, which are vitamins and minerals, and there are macronutrients like proteins, carbohydrates, and fat. So we are basically supplementing proteins. And then we give bile salts to our patients, and I'll just show you why we do that. Now, bile salts are given because in any weight loss, it's not related to only bariatric. Any weight loss leads to processing of fat in the body, and there are free fatty acids which are processed in the liver, and there is increased cholesterol concentration in the bile. So the bile becomes more lithogenic, or it forms more stones with weight loss. And if we give them bile salts for 6 months, then this lithogenicity reduces to about 2%. That means if 100 patients are given this, only 2% are likely to form gallstones because of weight loss, and which is a substantial benefit. And this is required only for first 6 months. After 6 months, we get their ultrasound done, And if there are no gallstones, we stop the bile salts. So this is how we manage, and these are ursodeoxycholic acid 600 milligram given twice daily, usually after meals, to avoid the gastritis. Then this is discussed in detail about endocrine impact. I'll just show you one slide about it, that after surgery, all patients have reduced insulin resistance, and thus the body is producing less insulin. So because pancreas get rest. So before surgery, their insulin levels may be 20, 24, 30, 70. And after surgery, because the insulin resistance is less, gradually the insulin requirement goes down and insulin production goes down. And the pancreas is able to protect its reserve. And then similarly, there is a reduced ghrelin level. Ghrelin is secreted usually from proximal bowel, especially stomach. And thus patients after bariatric surgery have low hunger compared to a diet where the ghrelin level goes up and the person is hungry all the time when they go on a diet. And the third major endocrine impact is on the GLP-1 hormone, which is secreted from the distal bowel, let's say that's distal small bowel, ileum and distal jejunum. And this all the physicians know, this is responsible for better glycemic control. There are many other hormones, but I wanted to make it compact, and we can discuss them in question answers if you wish to. Now, as far as medical management after surgery is concerned, so if a person had diabetes before surgery and is after surgery, the sugars are fluctuating in the initial 1 or 2 months, then it's better to use biguanides and sulfonylureas. And the reason is that if we continue to give them insulin, the normoglycemic level or euglycemic level takes time to be achieved. While with this is more experience based, there are no studies done on this, but this is what has been realized, that these two drugs help. Then antihypertensive medication should be continued after surgery, and only a family physician or a physician should stop it under supervision. Most of the time we have realized that patients start having postural hypotension if they continue with the antihypertensive for very long. And this postural hypotension can be reduced or avoided if the antihypertensive medication is reduced or stopped by the physician. So please watch out for postural hypotension in your patients, and you can help them directly. These are not hypoglycemia. These are mostly postural hypotension. Then we know that thyroid medications are generally not stopped after bariatric surgery, but as the weight of the patient goes down, the thyroxine requirement goes down, and it's a good idea to monitor their TSH levels. And as it goes down, you can probably reduce the thyroxine supplementation. Sorry. Similarly, for gout, we avoid Xyloric in these patients because we do not want severe gastritis or other issues. So it's a good idea to monitor their uric acid because we are supplementing them with proteins, and to start Fabustat to control the uric acid levels. And believe me, none of the patient requires protein to be stopped, because after surgery, we are replacing the proteins which they normally get from the diet. So please don't stop proteins of bariatric patients. If the uric acid levels are very high, maybe you can reduce the quantity of protein for a few days, start Fabustat simultaneously, and the moment it comes within the range of 6 or below, you can increase the protein and continue with Fabustat. And once the uric acid has come down substantially, you can stop the Fabustat. So proteins are required and they should be given. Now, a controversial issue is lipid-lowering drugs like statins. Now, post-bariatric surgery, it is known that cholesterol levels become normal, triglyceride levels become normal, but it takes at least 1 year, and this is because there's a processing going on. So it's a good idea that we don't expose our patients to cardiac risk, and it's a good idea to continue with the drugs that you are giving before the surgery for at least 1 year. And generally 1 year later, the cholesterol and triglycerides come within normal range, and then you can definitely and you should stop these drugs at that time, 1 to 1.5 years after surgery. Friends, it's important and it's to remember that after bariatric surgery, if a diabetic patient, if they get an infection, the sugars can go up. So patient may tell you, I had a bariatric surgery and I don't have diabetes, but please ask them that, did you have diabetes before surgery? Even if they are not on medication, but if they have any pneumonia or urinary tract infection, it's a good idea to start them on insulin, check their blood sugar. And similarly, patients may have low blood sugar after bariatric surgery because all of them have excellent glycemic control. So we need to keep a watch on that also. Please do not stop supplements of a bariatric patient. So if they are admitted or have any other disease, either continue in an intravenous form or continue the oral supplements. Supplements are extremely important, and it's a good idea not to change the supplements prescribed by a bariatric program, because we are our dietitian is able to identify the supplement RDAs of various vitamins and minerals and give a supplement accordingly, which are not the normal supplement. These are bariatric supplements. Then for other analgesics, other medication, antibiotics, usually 3 months after surgery, they can be prescribed. It's not necessary to avoid them, but obviously combination analgesics should be avoided so that we don't have gastritis or gastric perforations. Whether other procedures, other surgeries, deliveries can be done after bariatric surgery, certainly there is no limitation. A lot of our patients who travel from overseas have a second surgery 7 days after bariatric surgery. So any time after 7 days to a month later, people have like a knee replacement after bariatric surgery after 1 week. So this is all possible, and do not worry about this. And this is a small word of caution for you. Now, bariatric patients may get constipated because they are eating a very small meal, and the intestine absorbs most of the nutrition from there. So there is hardly anything left to form the bulk. So it's a good idea to offer them whole grains. So it has some fibers, vegetables and fruits, but still the focus is on the protein. So they really do not get enough. So now giving them isabgol doesn't help, because isabgol is a bulk former and it's very difficult to be consumed by a bariatric patient. So nowadays we have soluble fibers available. I'm sure you are aware of it, like Climalex or Nutrilite fiber, which is transparent, which mix in the water, and it's so easy to drink, and it doesn't stain in the stomach. So it doesn't form a bulk there. So it forms a bulk further down, and the person is able to eat a bariatric diet after this. A patient should be encouraged to continue regular exercises because that helps in their constipation. And if they are constipated, do not hesitate to prescribe laxatives, because usually constipations are there for about 3 to 6 months at the most, and non-habit forming laxatives can certainly be used. Another thing that physicians should know, that there is a term called dysgasia and dysosmia, which are disorder of taste and smell. So patients may complain that they don't like rice, or they don't like chicken, or they don't like water, or they don't like something. It is a real problem. It's not something in about 5 to 10% of bariatric patients, not in all the patients. There may be patients who have dysosmia, that they find a smell of, let's say, garlic beer in the house not acceptable, which they were loving before, or a smell of anything being cooked. And this is simply a matter of time. It is not long lasting. They are self-limiting. And this is probably because the ghrelin affecting the olfactory hormones. There is a study being done on this. So it's a good idea to rule out deficiency of zinc, copper, and nickel, which may contribute for this. And usually avoiding these particular stimulus is enough for about 1 to 3 months, and then the person will be able to consume them again. A quick word about what is the standard advice of supplementation after bariatric surgery. So proteins about 1 gram per kilogram of ideal weight is enough. Multivitamins like 1 to 2 times daily, depending on the which kind of multivitamin we are using. Calcium citrate, calcium in citrate form or fumarate form with vitamin D, about 1000 milligram of calcium citrate a day. Vitamin B12, in India, we get the sublingual tablet, very good. They don't need injectable vitamin B12 of 1500 microgram twice weekly is more than enough for sublingual tablet. And similarly, iron in a ferrous sulfate form, ferrous sulfate form is better. And similarly, the bile salts, as I mentioned, 600 milligram twice daily for 6 months is enough. And it's a good idea that these people are monitored for their vitamins and my macronutrients. So these are the tests which we usually advise them to get done at 6 months. Ultrasound is done only at 6 months, not thereafter. But other tests are done on an annual basis thereafter to make sure that they are having no deficiencies. And I tell you, almost 19% of our patients have no deficiencies after bariatric surgery. All of them had deficiencies before surgery, but the nutrition status improved after bariatric surgery. So, to give you a brief mnemonic, weapons of bariatric surgery with a different spelling is water, exercise, proteins, no snacking, and supplements. It's very easy for patients to remember, and you can tell them to follow this. So, friends, surgery is not the end. It's a beginning of a weight loss journey, a beginning of a healthy journey for patients. And please be a part of it so that your patients feel good about their health. So thank you so much. I'll be very happy to take questions from all the members and when Dr. Pardiwalla and Dr. Seema Srivastava, who is here, about these medicines.
Thank you so much, Dr. Raman. That was a lovely presentation. So I would first read out the question to you from one of our viewers. So the question is that with post-operative reduction in food intake and intolerance for meat and dairy products, it usually causes iron deficiency anemia. So what should one try to do to try maintain the iron levels? And what are the best tests for detecting the iron deficiency?
Yeah, so iron deficiency is definitely an issue. And as many of the patients, especially women in India, already have pre-existing iron deficiency anemia, it is even a bigger challenge in India. And so most of the patients are prescribed, especially the bypass patients are prescribed ferrous sulfate on a regular basis. And we monitor their iron and hemoglobin levels. We have found ferritin to be more reliable indicator than other tests. And if we find that there is indeed an iron deficiency, which is not getting corrected, we give them IV iron once in 6 months, and that keeps the reserve levels high up. And at the same time, they are also prescribed oral tablets. So it's a combination depending on the demand of the patient. So a woman during the menstrual age probably require IV iron if they had a bypass. But if they had a sleeve, the oral tablets are enough. So it's a more of an individualized approach based on their requirements.
Thank you, Dr. Raman. So there's one more question, something related to that. So how should one tackle the issue of post-op reduction in bone mineral density?
Okay, I think that's a great question, because bone mineral density can indeed go down, especially in bypass patients. And that is why we are so particular about calcium supplementation, about vitamin D supplementation, and we encourage them to exercise. So exercise is an important component of maintaining the bone architecture, and especially in more senior people. So I think all the three, and it's a good thing nowadays. Everybody says that vitamin D level should be around 60, not, just keeping it around 30 is not enough. So we like to give them injectable vitamin D besides oral supplementation. And so once in 6 months, when we check their vitamin D3 level, and if it's low, we give injectable vitamin D3 and we continue with oral supplementation. And most of the patients are able to maintain this between 30 to 60 with this kind of approach. And it's important to remember, Dr. Unnati, these people have come to us before surgery with vitamin D levels of 9 or 10 or 13 or 18 or 20. Most of them are below 30. So if the patients are able to maintain above 30 and the bone architecture is maintained much better.
All right, all right. Thank you so much, Dr. Raman. So, Dr. Behram, Dr. Seema, do you have any questions for Dr. Raman?
Raman, one question. Do you recommend different surgeries for weight loss and different surgeries for diabetes?
Yeah. So, sir, initially it was thought that we have different procedures we need to devise, different procedures for diabetes. But the procedures which were devised for diabetes were like ileal transposition. I also started doing that very early in 2008 at Bombay Hospital. I was there and we published our data in 2011. They are quite complex surgeries. And what happened in the meantime, the cutoffs were reduced by International Diabetes Federation. At that time, we were not allowed to do these surgeries below 35 BMI. Now we are allowed to do standard procedures at 27.5 BMI. That means if somebody is like 10 kg overweight and is diabetic, we can offer a regular surgery. So I don't think we need to do the novel surgeries for them. We can offer them gastric bypass or a sleeve gastrectomy, which gives equally good result, which are more standard procedures, and they do not lead to excessive weight loss. Somehow, the body has this homeostatic principle that if we do it at 28 BMI, they will probably come down to, they will lose 7, 8, 10 kgs, or they will come down to 25 BMI and they will stop. So it's extremely rare to find somebody who has lost more than 100% of their extra weight. So the excessive weight loss fears are not there. And these surgeries give, both the surgeries give almost equally good result in an average diabetic. But if somebody is diabetic for a longer duration, if somebody is on insulin for longer duration, I would prefer a gastric bypass for sure. But if somebody is diabetic for 2, 3 years, 5 years, not on insulin, sleeve gastrectomy gives equally good results. Dr. Unnati?
Yeah, all right, sir. I had lost you for a second. Dr. Seema, are you there with us? Do you have any questions?
So maybe you can run the video of the patient, Dr. Unnati, and then she can ask the question.
That also works. Okay.
Yeah.
So Pushpendu, can we have the
Dr.
patient's
Seema is
video?
there now. She can probably ask.
Okay. Sure, please.
Dr. Seema, anything for the bariatric surgeon? We can't hear her. At least I can't hear her.
So there seems to be an audio problem, Dr. Raman. So do you want to go with the patient's video first?
Okay. I mean, if Dr. Seema is comfortable with that. All right. So, Dr. Nati, just start the video. Yeah.
Sure.
Hello. Hi. I'm Ilham Marolia. I'm 60 years of age. And at the age of 52, I was very much depressed. and I had hypertension, I had diabetes, had lots of problems. And as I'm short, it was really very bad for me to move on. And one fine day, I heard about Dr. Ramen Goel, and I went to him with my husband, and he explained us everything. And on that very same moment, I told my husband I want to go in for the surgery. And just in a day's time, I took my decision, and then I went for sleeve gastronomy operation. That was in the year 1940. 2040. And now it is nearly 6-7 years after the bariatric operation. And I was really very much depressed when I was having this hypertension, diabetes. I was not going out. I was never into not a person to go out to enjoy myself. And after the bariatric, I really went and I improved it. So I got my life again.
I would like to congratulate you, Hila, for your surgery and that it went well and that your lifestyle has improved. It is great to know, and we are very happy to have you on board. And thank you again for coming out and sharing your experience. So I just have a couple of questions for you.
Yes,
So before gastric, so like you told that you went and visited the doctor, but what was the motivating factor? What told you that okay, you have to go for this? Did you try any weight loss?
Oh my God! Of course, yes.
Yeah, please tell us that experience.
Like many expensive medicines I took, just to reduce. Then I joined the gym, and very expensive gyms I joined, and I used to reduce 5-7 kilos, and then as soon as I stopped, it again shooted up. My weight shooted up, and it was like I just read Dr. Ramen Goel's article in the paper. That was the thing, and it was a Friday, and just I called up, and he has just left, and then they told me that you will have to wait till Tuesday. So I was like waiting till Tuesday, and then I got to see him. I was with him for 3-4 hours, and then I made my mind that I want to do it. So I did.
Great to know that. And so how has your journey been during the bariatric surgery and post bariatric?
Yeah. See, I'm a catering person. I have my own restaurant just now. But before that, I used to cater from my house. Okay. I used to cater 150 tiffins, But after getting all this, I left it. Now, after the bariatric, in a year's time, I got a restaurant over here in Udwada, which is in Gujarat. And I'm really doing it very well. My son is also there with me. And now everybody is like, Hilla. Well, nobody was asking for Hilla. It was like that.
Great to see that enthusiasm and great to see that you have, done so well after the surgery. So just wanted to know that.
Now so I just put my hand on any clothes and I get it, It's like that. First I had to go to stores,
Amazing. So I just wanted to know that how did all of this affect you psychologically? How did you deal with it? And what were the major lifestyle changes you had to adopt?
Okay. Now, see, when I was fat, I should say I was fat. Definitely I was fat. So I was into very much depression. I was never going for outings, no parties, nothing. I used to sit in the house. I never used to eat also, that. I was so much into depression. And after the operation, my lifestyle has fully changed, that I just have a small quantity of my portion. Still, I do it. I still take one roti only for my food, or a bowl of rice and dal and curd and lots of salads I'm having. I have my chicken, mutton, fish also, but in a very moderate manner. I eat sweets also. I have a very bad sweet tooth. So I have it, but in a very small quantity, you know.
So glad to know that you adopted all these changes. And again, thank you so much for coming out and sharing.
Yeah, this all credit goes to Dr. Goel and his team.
Great.
All
great,
credit
great
goes to
know
Dr.
that.
Goel and his team.
And I hope your
swear,
testimonial.
I still, yeah.
Great to know that, Miss Hila. And I hope your testimonial is going to inspire a lot, many other people and a lot of our family physicians.
Thank you so
and
much.
inspire
And I'm
other
really,
patients.
yeah, I'm really
Thank-
great that you called me on the Zoom, and I'm really pleased to, you know.
Thank you
I'm
so
really
much.
pleased.
Thank you so much. Thank you for taking out the
Okay.
time. And I think, thank you for
Thank you,
being
dear.
here.
Yeah, Dr. Unnati. So,
Congratulations, Dr. Raman.
Yeah, thank
She
you.
was very happy to share her experience, and I think the credit goes to you.
Sir, you are saying something?
I think you should go to Urvada one day.
We should go together, sir. She has a restaurant there, and she has been inviting us for a very long time. And the reason why we are calling a patient in a CME is our physicians, family physicians, see them when they refer them for surgeries, but they don't get to see the human side of their recovery. They see that sugars have improved, blood pressure has improved, but they don't realize how it is affecting them as an individual, how it's affecting their interpersonal relationships, their productivity, which is outside the clinic. So if somebody visits Dr. Pardiwalla will check the blood sugar, blood pressure, and will say, okay, you're doing well. But how the person is doing at home is so important to us, all of us, ultimately. Yeah. So, yes, Dr. Unnati.
Dr. Behram, do you have something to add? Do you want to say something? No? Okay, then I think we have had a beautiful session today by both Dr. Behram and Dr. Raman. And the patient's testimonial only added value to the entire program. So I would like to thank both of you. Yes, Dr. Raman, please.
So before you close, I would like to thank Dr. Pardiwalla sir for his presence and time. It's so difficult to get an appointment for a patient for 15 to 20 days with him. Forget calling him for a CME, you know. Though I'm able to manage the consultations always for my patients with him. And so thank you so much, sir. He is not only my patient's physician, he treats my entire family and my personal physician. So it's an honor to have him around. And a person with a very broad outlook. So when you send a patient to him, he looks at holistically. So it's not a question of a particular disease. And every patient comes very happy. You know, once he goes to them, they always say, thank you for sending us to the right person. So thank you, sir, once again for joining. And thanks, Hila, for such wonderful testimonial and your sharing your experiences. It takes real effort to talk openly about their own health problems on a public platform. So thank you so much. And thanks, Dr. Unnati. Please go ahead.
Thank you, sir. Thank you, Dr. Behram. It was lovely having you here. We would look forward to hear from you again soon. We will get back. And Dr. Raman, thank you for organizing this program. So, and I would like to thank all our viewers who are with us. Please drop many questions. We will get back to you with the answers. And I will see you all next Thursday with another episode of this. Till then, please stay safe, stay connected. Happy Docplexus. Thank you, everyone.
Thank you.